Welcome to a webinar by the American Society for Reproductive Medicine's COVID-19 Task Force. Our panelists will be presenting on ASRM's recommendations and the new update number 3. I am Sarah Amaya, Curriculum Designer at ASRM with my colleague Jessica Goldstein. This webinar will be moderated by Dr. Samantha Pfeifer. Dr. Sam Pfeifer is an Associate Professor of Clinical Reproductive Medicine at Weill Cornell Medical College and specializes in infertility and reproductive surgery. She's been involved with ASRM for many years and has served as the Chair of the Practice Committee, President of the Society of Reproductive Surgeons, and is currently a member of the ASRM Board of Directors. Before we begin, please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type your questions in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn this webinar over to Dr. Pfeifer to introduce the panelists and moderate the session.
Thank you, Sarah. I appreciate that introduction. And I welcome everybody to this task force webinar on the COVID recommendations put forth by the ASRM task force. Our first recommendations were issued on March 17th, which is just over 6 weeks ago, which seems like an eternity in our social distancing mode. But since that time, the task force has put out two other updates on the recommendations. And we have now put out the third update recently. I think it's important to note that the task force over this past 6 weeks has evolved and grown. And this recent update task force has been made up of a very diverse group of members. Many of them, or most of them, are ASRM members. We have the ASRM Executive Board on the task force, the CEO. But included in the task force, we also have members from reproductive infertility specialists who are in academic medicine, private practice. We have laboratory representation. We have those with expertise in epidemiology and mental health. And we also have patient representatives on the committee. So it's a very diverse group. With that said, I think I would like to introduce our speakers. We have Natan Bar-Chama, Marcelle Cedars, Enrique Schisterman, and Elizabeth Hern. And we're going to start off with the first presentation by Natan Bar-Chama. He is currently the director of the Center for Male Reproductive Health at Reproductive Medicine Associates of New York, and is currently on faculty at the Icahn School of Medicine at Mount Sinai. Dr. Bar-Chama currently serves as president of the Society for Male Reproduction and Urology of ASRM. Dr. Bar-Chama?
Thank you. As a global community of professional medical society and individuals, we continue to struggle with the COVID-19 pandemic, which has exploded into an unprecedented health, humanitarian, and moral crisis. In the United States, more than 60,000 Americans have died from the virus. The number of infected cases, while underappreciated, is beyond 1 million. And the coronavirus continues to upend normal life in the U.S. economy. There are, however, signs of hope as areas of the United States experience sustained lessening of the toll and begin the process of opening up society and resuming healthcare access. In the early stages of the U.S. COVID-19 pandemic, and in accordance with other medical societies and government guidelines, the task force recommended implementing a moratorium on non-urgent care until the conditions on the ground, the ability of healthcare systems to deal with disease surge, and their transmission rates could be better defined and managed. The task force was guided by a sense of urgency and empathy, seek collaboration and common purpose within ASRM, and always hoped for resumption of fertility care under improved conditions. The task force was and continues to be committed to reviewing the evolving science of the pandemic and updating the recommendations every 2 weeks. The task force reaffirms that infertility is a serious disease that requires treatment in a timely manner and that fertility care is an essential health service. With the passage of time, an increasing number of patients whose care has been delayed due to the COVID-19 pandemic are now in a situation that has become more urgent. Nonetheless, the task force recognizes the need to minimize the spread of COVID-19 and preserve critically needed local healthcare resources to address the pandemic, while simultaneously acknowledging the essential timeliness and importance of access to fertility treatment. It has now become more apparent that there are geographical differences in disease prevalence, impact on regional and healthcare resources, and timing of the apex of disease incidence. Aggressive and unprecedented mitigation strategies, including social distancing, stay-at-home decrees, increasing healthcare capacity and resources, have in some localities successfully resulted in flattening of the transmission curve. While the peak impact of the pandemic appears to have been reached in some communities, there are others where the burden of the crisis continues to rise. While not lessening concerns for the severity of the disease, these developments across the United States cautiously suggest that most patients falling in with COVID-19 will be able to access the care that they need in the context of a healthcare system that is not overburdened. Living and operating in a society where COVID-19 exists is becoming our new reality. COVID-19 will remain a factor to be managed in our lives and practices for a prolonged period of time. The ultimate response to this pandemic may rely on the development of a vaccine, effective treatments, or both. Until then, expanding testing, contact tracing, surveillance strategies, quarantine protocols are needed to guide this ongoing public health response. Collectively, with humility and resolve and guided by science and principles, we need to continue to closely monitor this pandemic and be responsive to its trajectory as we proceed to provide fertility care in the era of COVID-19.
Thank you, Dr. Bar-Chama. I would like to introduce now Marcelle Cedars. Dr. Marcelle Cedars is the director of the University of California, San Francisco Center for Reproductive Health, the Division of Reproductive Endocrinology and Infertility, and she is currently vice president of the American Society of Reproductive Medicine. Dr. Cedars?
Thank you. I'd like to shift at this time to talking about more of the specifics of the recommendations in update number 3. Before you resume care, there are a number of things that you should consider. First, obviously, follow all of the national, regional, state, and municipal guidelines. And even if the guidelines are starting to loosen in your particular locale, it's always a process of balancing risks and resources within the community. We recommend at a minimum that there be a sustained decline in local cases for at least 14 days, and that the hospital capacity is such that if there's an increase in cases, which there almost surely will be as we start to loosen the shelter-in-place hold, that the hospitals can maintain care without slipping into crisis mode. You should prepare what care will look like and how you can do this, limiting risk to patients, staff, and society. And we encourage a formal risk assessment, and I'll talk a bit about what this would entail, and that you have a documented risk management strategy. Before you resume care, it's important to think about how you will resume care. And we recommend that you reinitiate cycles in a limited way because you're going to be putting in place new policies and new procedures, and you need to make sure these processes work. You also should be prepared to continuously monitor and reassess these processes, because despite your best efforts to determine where your risk points might be, until patients start to come into the clinic at an increasing volume, you may not know which areas are most at risk. The formal risk assessment should include, at a minimum, an assessment of what the potential harm is. And obviously harm here is infection of your patients' families, your staff, their families, and transmission within the clinic. And so you need to think about where those risk points are, evaluate systems of how to limit harm or risk, develop a plan to control that harm, and then discuss and determine who will carry out each specific action, implement a timeline, and again, constantly reevaluate and modify as the process resumes. Once you actually start to see patients, you need to think about risk mitigation. How do you decrease the risk of harm, this risk of transmission within the clinic? And there are aspects of this that are dependent upon the healthcare system and aspects dependent upon the patient. So there should be written policies and procedures for risk mitigation. And you need to verify that all staff have reviewed these, and potentially even have a way to document that all staff have reviewed these. These are new processes that are not standard in your clinic. And so making sure all staff understand the processes and how to implement them and what their individual role will be is critically important. Utilize national and local healthcare organizations, your local health department, the FDA, the CDC, NIOSH. We've listed a lot of these resources in update number 3. And you should utilize all of these resources, and most importantly, remember that they're not static. There are updates on an almost daily basis, and so what you decide today may not be what you want to implement a week from now or a month from now. So familiarize yourself with these resources and follow them on a regular basis. And then we suggest that you have specific policies for patients who themselves might be high risk based on age or underlying conditions, who may have a high-risk family member that they go home to at the end of the day, what to do to make sure you're adequately staffed with sick day planning and that your staff are protected if they do get sick, and then have a formal return to work policy after your staff has been ill or put on quarantine. From the patient perspective, most patients have already heard about wearing a mask, washing their hands, social distancing, but help to educate them and make sure that you're reinforcing these behaviors. Talk to the patients about the risk in this treatment time or treatment in this time, what we know about COVID and coronavirus and what we don't know, and what potential risks might be for pregnancy, and discuss timing of pregnancy. And also discuss with them the risk of cycle cancellation. If they get sick or become symptomatic or test positive during a cycle, their cycle will likely be canceled, and they need to be prepared for that. Or it's possible that there's a flare and the cycle's canceled because there's an urgent crisis again, like we had in March. Hopefully not, but patients need to be aware that this is a very changing dynamic. In clinic safety, you want to maintain physical distancing, and this might be in space or in time. So how do you set up a system that works? And everybody's clinic is a little bit different. And so how patients funnel into the clinic. Do you have a problem or a bottleneck at your front desk? Can you spread patients out through the day more than you did perhaps? Can you spread them out physically within the clinic So you need to know your own physical and time constraints in order to develop a policy that works for your system. You should daily screen patients and staff, and we're talking about questionnaires here. Have a very strict face mask policy. Establish your cleaning policy. There are differences from bloodborne diseases in terms of key touch points in the clinic, particularly doors, computers, places that patients and staff touch frequently, and frequent hand washing for staff, for physicians, for patients. What about testing? There are a lot of questions, and you'll hear from Dr. Schisterman, who go through some of the points about strengths and weaknesses and where we are on capacity for testing. But obviously, the ideal situation is that we had a rapid point-of-care test that we could do for every visit, for every staff, but we don't have that. And be very cautious about the tests that are available and things that are being marketed to you. You should only use FDA-approved tests, and there are a lot of tests coming to market that have not been approved and have very poor predictive capability. So be very careful. Understand the difference between testing for the virus itself with PCR or testing for the antibody, and what testing for antibody might actually mean. There are special circumstances, certainly prior to surgery, that will require an intubation. All patients will be required to be screened. The testing prior to anesthesia for an egg retrieval is going to be dependent upon your own local facilities, but it's suggested that you might consider testing prior to the start of stimulation because of the risk of cancellation, and then more closely to the time of the egg retrieval. And then again, what do tests mean? Everybody's looking for, I want to check my box. I'm antibody positive, I've been exposed, I don't have to wear masks, I don't have to take precautions. We aren't there yet, and we may not be there. So this is why, just as we use universal precautions with wearing gloves and protection from bloodborne diseases, because we don't know who may carry hepatitis or HIV, we need to universally protect in terms of masks, regardless of any development of testing further. So in summary, start when it's safe in your community and when you have been able to develop guidelines within your community that will allow you to practice safely. Practice physical distancing. Again, this may involve both modifications of your system, both in time and space and how you see patients. Everyone in the clinic, all staff, all patients must have face masks. Practice both universal precautions and, in certain procedures, expanded precautions, particularly in terms of risk from this virus in terms of droplet and aerosolization. Continue to utilize telehealth as much as possible for visits that don't require an in-person visit. Have staff working remotely, so your staff have physical distancing. And then assure, if you have staff working remotely or you have staff that are working in teams so that all your staff aren't in the clinic at the same time, that you assure adequate staffing for the volume of patients you're seeing and the procedures that you'll be doing. And remember, this is an iterative process. What you design today will not apply, I can almost guarantee you, a month from now. So you need to continually monitor, reassess, and modify. This may change as the transmission within your local environment changes, and it will change as our testing modalities and in recommendations of our local and national healthcare organizations improve their guidance for us. Stay updated, read literature, pay attention to patient risks and testing, and most importantly, for both patients and staff, make sure that you have mental health support available. These are trying times for all of us, but ultimately stay safe and stay healthy.
Thank you, Marcelle. now like to introduce Dr. Enrique Schisterman, who is a senior investigator and epidemiology branch chief at the Eunice Kennedy Shriver National Institute of Child Health and Development. He is a reproductive epidemiology specialist, and he will now present the epidemiologist perspective to the new ASRM guidelines. Dr. Schisterman.
Thank you. Thank you so much. I'm thrilled to be here today, and I have been actually thrilled to be part of the last update of the guidelines. This is a very evolving disease, and I'm sure you have all seen this map, and it keeps changing by the day. This is yesterday's map, and clearly is outdated today. But the pattern that we have been seeing is that there are tremendous regional differences in the incidence of the disease across this humongous country. So it makes sense that the guidelines that we develop together will have to be less rigid and more flexible depending on where you practice. I want to repeat something that in the introduction was said, that the committee was composed of a large array of different disciplines, very collegial, and perspectives in the task force. Included clinicians from big institutions such as universities and hospitals, included clinicians from private practices, and some views of that are different, including patients, including other scientists, virologists, embryologists, mental health specialists, and epidemiologists. So it makes sense that at the end we end up with a very flexible guidelines on how we are moving forward. I want to focus on two salient points today, on very eloquently presented by Marcelle, the guidelines, and two things that we need to be thinking forward for the future of our patients. One will be risk mitigation, and two is testing. I realized that the data that we based our guidelines last week is already old, and some of the things that we decided last week have changed radically. You heard all yesterday, there is a new treatment that shows some promise. There is no new testing, saliva-based testing that shows a lot of promise. And the models are projecting and are changing because the data keeps updating. So even the projections of the number of cases and the number of deaths that we're going to experience in this country has changed in the last few days. So with that in mind, I want to focus on two basic epidemiological principles. I know we talked, and you have seen this graph about flattening the curve, but I wanted to focus on flattening the curve as it applies to reproductive endocrinologists and our patients to come to get treatment. We're going to experience, because we closed for a while, a backlog of lots of patients who are looking for getting treatment. So this is also, we need to protect the system that we are have in place to provide fertility treatments to all the patients that may need it, in combination with the existence of the coronavirus. And so the principle of protecting the system, it doesn't go only to the first responders, but also to our doctors, nurses, and patients. And then I'm going to talk about testing. I think that we keep hearing about testing, and it's not available, it's not widely available. That's why it was not recommended to be test everybody, because we don't have the capabilities today. But one of the concerns that it was brought up all the time is that the sensitivity is low, is approximately 70%. I want to be bringing this up because the alternative that we have today for those who are able to get these tests is actually testing for symptoms. And it's not a better test, it's testing for a worse test, which is, what are the symptoms that may appear between days 2 and 14 after exposure of the virus, and we have an array. So that's the test we have today to evaluate if somebody has the coronavirus or not. So you have fever, you have cough, you have shortness of breath, chills, repeated shaking with chills, muscle pains, headaches, sore throat. And so the question that we need to ask ourselves, if any of those questions are asked and are responded positively, what do we do with those patients? Do we send them home or not? So those are things that we need to be thinking about, or you should be thinking about while you develop your guidelines in your own practice. This is basic epi. And so I took 100 patients using each of these two methods, meaning the more sophisticated method that has a relatively low sensitivity of 70% compared to using that questionnaire and measuring fever. And you can see that using the one that we don't like so much with a prevalence of 12%, only 12% of the patients will be turned away with a sensitivity of 70%. However, using the symptoms, if we find a combination of all those symptoms, actually approximately 46% of those patients will be turned away. So we need to be very clear what we want to do with those tests. And on the other hand, we're going to, in using the PCR test, you're going to be sending away, you're going to be exposing your staff and patients to 3 out of 100 compared to 5 out of 100 using the questionnaire. So I can change the assumptions that I made about testing. The testing vary between 35 and 80%. But what I want to emphasize is that a decision needs to be made. What would you do when you use those questionnaires with those patients? Are you going to treat them anyway, or are you going to send them away? And if you send them away, for how long, and so on. We did the same thing, varying the specificity and the sensitivity from 50% to from 35% to 80%, and it shows that those numbers are constant. And the more I change those, the more patients I will be sending away or turning away, and even more extreme, and I will be even turning away even more patients. So we need to be thinking, how are we going to be using those questionnaires to decide what to do with those patients? So that's something that you all should be thinking about. But testing, when becomes available, and one day will become available, and it will be inexpensive, and it will be good testing, will allow us to treat more patients. I'm sure about that, and will allow us to keep patients and staff more safe in the process. We are going there. We need to be thinking about that. The other thing that I know you know this, but the prevalence of the disease will affect what we call the positive and negative predicted values. So in areas that the prevalence of the disease is high, having one of those symptoms positive or a test positive will imply that they are more likely to have the disease, and the other way around. I wanted to finish by thanking the ASRM for being so thoughtful and putting together a very flexible guidelines where they prioritize patients. And I ask everybody to stay safe, prioritize your patients based on their need, and testing will help us move and flatten the curve. And with that, thank you so much.
Thank you, Dr. Schisterman. I'd now like to introduce Elizabeth Hern, who is a patient representative on the COVID task force and has been incredibly helpful in representing the patient perspective as these recommendations have been developed. Elizabeth?
Yes, thank you so much for the introduction. My name is Elizabeth Hern, and I am in fact a patient representative on the ASRM COVID-19 task force. And I wanted to speak a little bit on my involvement with the task force today. First, a little background. My husband and I have battled infertility for the past 4 years. When I first started this, my therapist and I were referred to the journey as a marathon. But based on everything you can see on the screen, I think we're now in the ultra marathon territory, and we are continuing to fight our fertility battle, and have been working with both an academic clinic and a private clinic in Atlanta. We had begun medication for an IVF retrieval cycle at the beginning of March and ultimately canceled that cycle due to the COVID-19 pandemic. Shortly after canceling, I was asked to join the ASRM task force, and I've been a member of the task force since March 25th. I've participated in all of the task force meetings and received all the emails, and I was a member of the subgroup that drafted the recently published update number 3. As far as my thoughts on the recommendations, first, while I strongly feel that infertility is a disease and is not quote unquote elective, and while time is of the essence for me, given my age, I'm 38, and my profound diminished ovarian reserve, I fully support the task force's recommendation. At the end of the day, for me and my husband, and we've talked about this a lot, the COVID-19 threat to ourselves, our families, the healthcare workers, pharmacists, and the general public really outweigh a short delay in our personal fertility treatment. Second, as a member of the task force, I appreciate and understand how much thought went into making the initial recommendations, and I understand the rationale behind those recommendations. I can personally attest to the fact the task force wants care to resume to normal as soon as possible, and I hope that this is evident based on all the detail that was provided in the task force's 3rd update. At the beginning of my journey, one of my doctors would always use the word reasonable. And I never told her this, but it kind of drove me crazy. And hopefully she's laughing as I say this. I always wanted to hear that something was either right or wrong or a clear yes or no. But as I've learned, and you all already know, that's just really not how this disease works. And the word reasonable has grown on me over the past few years, and I've started to use it frequently myself. So since the pandemic started, I've really tried to think in terms of reasonableness. So for me, it's reasonable that reproductive care would be delayed if certain cancer care is being delayed or transplant surgeries. I don't think reproductive care is being singled out or targeted in that way. It's reasonable that reproductive care providers would want to reopen. It's not an us versus them type of thing. And I know that everyone on the task force and probably everyone on this call wants to be able to safely resume care as soon as possible. It's reasonable that for me and my husband, a short delay is not going to materially decrease our chance of success. And I know that one day we will be successful. And finally, it's reasonable that one of the best, if not the best things that my husband and I can do to increase our chances of success is to stay healthy. I can't speak for all fertility patients, and that's not what I'm trying to do. But for me, any delay in treatment over the past 4 years has caused increased stress and anxiety. And there have definitely been some delays. Fighting fertility can feel like the ultimate loss of control. And I am someone who loves to be in control. The delays and the unknowns that come with COVID-19 are no different, and they just add to that stress. And the reality is that that can be a really hard pill to swallow, especially when there's so much stress around us. So in case other patients find it helpful, I thought that I would share a few ways that I have coped with the stress and anxiety over the past few weeks and couple months. First, I have continued virtual dialogue and appointments with my therapist. I'm a big fan of my therapist and therapy in general, and I really appreciate that we've mentioned that multiple times on this call and that we've included mental health in our updates. Second, I've continued to have virtual dialogue with my treatment team, with my doctors and nurses, and have begun planning next steps, which I think is always helpful in reducing stress. Third, as I mentioned on the prior slide, I've tried to think reasonably about all this. And along those lines, fourth, I've tried to avoid sensationalized media stories. I realized early on that rarely has Google or social media, those type of things, they haven't really been helpful to me in my journey. And I've found that this is no different. So I've tried to avoid those type of stories. A few thoughts on my hope for reproductive care moving forward. I believe that not only is it possible, but it's imperative to resume providing reproductive services in an environment where COVID-19 exists. This isn't going away tomorrow, and I know that we all want to resume care safely, and that's what we've talked about on the call today. My hope for providers is that they are currently working to establish new protocols, procedures, and systems that allow for reproductive care to assume. And the task force update number 3 provides a lot of helpful information along those lines. And my hope for patients is that they remain positive and hopeful through what is a stressful, difficult time, but having a smile on your face just for me has always been helpful throughout this journey. Finally, I'd like to take a minute to say thank you to everyone on this call, all of the fertility providers, including my doctors, Dr. Jen Kawas and Emory Reproductive Center, and Dr. Catherine Calhoun and the Atlanta Center for Reproductive Medicine. What all of you do is really life-changing for patients like me. And so just with all the stress going on right now, I just really want to reach out and say thank you to everyone. And with that, I'll end.
That was wonderful. Thank you to all of our presenters. It was terrific. We do have some questions here. One of the questions relates to screening. The concern was raised that patients, if asking patients if they have symptoms of COVID-19 as our main strategy for testing may lead to patients lying about their symptoms as they are desperate. And what objective measures do we have that could potentially get around that issue?
That's an excellent question. I think that there is no real solution for people not telling the truth. What we can do is to try to put together a mitigation system where even when we have a patient who has the coronavirus, that we minimize the risk for everybody who is going to be treating that patient. What I was just trying to say is that basing the existence of the disease on the symptoms is not a great tool for that. That's all. We should be focusing on moving forward to try to use better tests beyond the evaluation of symptoms. And Marcelle, maybe you want to add something more.
Yeah, I just want to reiterate what Dr. Schisterman was saying. I think we don't have good testing, and certainly asking about symptoms is a very poor screen. It gives us some information, but we know from studies that patients can shed virus asymptomatically. And that's why we talked about that this is really like universal precautions. You should wear a mask all the time, regardless of your antibody status, regardless of what the patient says about their antibody status. Everybody should wear a mask. You should clean rooms, clean handles, things that are touched, wash hands, because we're not going, even when we have testing, no testing is foolproof. And so you're really going to have to assume every patient has risk and take these precautions every day with every patient.
There's a lot of questions here about testing. One question I think we've all just debated is if we test, how often and when is best? And I'd pose that to Enrique, you're up there, but also maybe Natan as well.
There's not optimal strategy for testing right now, given that we don't even have a test that we agree on. That will get cleared up with a little bit of time. There are many strategies that we could be thinking about. So, for example, you could test your patients at baseline, and if they have a negative test, do an IVF and have them stay at home for 14 days. There are many ways to do this. It depends on the prevalence of the disease in your community, the equipment that you have, the PPE that you have, the setting that you are. Is not, that's why the guidelines were so broad. It gives the opportunity to set it up in a way that will fulfill the needs of your community. Not every community is the same. And so no single strategy for testing will be ideal for every place.
It's also important to know how much testing is available And so even if you wanted to test every day, you can't. The tests just aren't available. And so when people have talked about testing healthcare workers, for instance, who have known exposure, they talk about conceivably testing every 3 to 5 days because multiple tests are more likely to yield a positive in someone who's truly infected. But we don't have the test capability to do that right now. So that's why we're being a bit vague, but it has to do with both the reality of testing and the availability of testing.
And to add one little thing about that is, remember, the principle of a positive predicted value is a function of the prevalence of the disease in your community. So if the prevalence of the disease is low, widespread testing is not as necessary. But if the prevalence of the disease is very high, then it will be more urgent to have a good strategy for testing, and we should push to have something more.
I think I would differentiate between the goal of testing and how far we need to, how it's eluding us at this juncture in terms of availability and predictive value versus screening. You know, screening is not just asking people if they feel okay. It's also when they come into the building, when they come into the office, they meet a health professional who's able to take their temperature, interact with them. And so you're putting layers, you know, before they see the physician or before they move into the next environment. You're putting in place protocols that are based on reality, which at this point is not testing based.
Thank you. Another question here relates to the statement, education and staff training are achieved and certified. And the question is, what is being certified and who is doing the certification? Maybe Natan, you can address that, or Marcelle.
I was just going to say, when I was talking about that from the guidelines, it's really about having a policy and procedure about wearing masks, how we clean the rooms, washing your hands. And then because this is such a difference from your normal practice, if you don't have a situation where all staff have to sign off on every policy and procedure that they've read it, this might be one where you might want to institute such a policy.
Another question relates to the timing of retrievals between patients if there's only one OR in the clinic, and how do you recommend cleaning the operating room between cases? Any recommendations on that?
So we don't have great data on this, but remember the primary concern is going to be respiratory droplets, and most patients aren't intubated for an IVF egg retrieval, and so the risk of aerosolization is very low. The likelihood for droplet if the patient's not sick and not coughing is low. So there should be cleaning between patients routinely. And so surfaces that are touched, although the patient's not touching much depending on how your process works, but any surfaces that are touched need to be cleaned between patients, but otherwise your cleaning between patients should be fairly thorough anyway, and you're just mainly watching for droplets. If you think there's a risk, if you have a patient who has medical complications and there may be a risk for intubation and aerosolization, then that patient probably shouldn't be done in your ambulatory center and should be done in a site, and certainly anybody who's known positive, done in a site that's set up and prepared for a patient with COVID.
I think the other thing I would add to that is an environment that is open to constant analysis, meaning that you put in place protocols, but you enable people to say, you know, and to communicate and comment on things that were missed or things that need to be improved upon, so that adjustments are made to optimize these the efficacy of these interventions, not as a static set of rules, but rather a coordinated, ongoing dynamic that is going to require attention and is life-saving.
Questions are raised about which masks are effective to wear in the office when seeing patients. Are N95 masks required when you see patients in the office?
There's still a shortage of N95 masks, and so I know in the Bay Area it's advised that those are restricted for known patients or patients where there's a high suspicion of COVID, and surgical masks are recommended, both within the hospital system, both for the patient and staff. Surgical masks are recommended and not N95, but that's due largely because of a shortage of N95 that still continues.
And a follow-up on that is, what PPE do you recommend for an egg retrieval?
So we're looking at the guidelines. We may have been overly conservative in terms of some of the guidelines in terms of the need for face shield. And I think a lot of that is going to depend on your risk for droplet or aerosolization exposure. And that's going to depend on your anesthesia and the underlying health of the patient.
One of the other couple questions are coming in regarding the risks of COVID-19 on an early pregnancy or in pregnancy in general. And what are recommendations we are giving patients, and are we discouraging patients from getting pregnant at this time due to the virus?
So I'll start that, but then I'd also like Elizabeth to chime in because she's in that situation of having to make the decision herself. I think the most concerning thing is we don't have data. We don't have data about first trimester of pregnancy. This virus has only been around since December of 2019 in China and since February in the US. So none of the women who potentially were exposed or infected in the first trimester are anywhere close to delivering. And we don't know what the first trimester risk is, which is why we're trying to do a study, quite frankly, to look at that. But we do know that high fever is a risk in early pregnancy, a risk for miscarriage, a risk for birth defects, a risk for preterm labor. And so certainly trying to minimize risk of exposure if you conceive. I think the problem that we're going to face is that we've done such a good job with the social distancing of flattening the curve that if you saw that picture that Dr. Schisterman put up, this means the virus is going to be with us, and Dr. Bar-Chama said the same thing, for 12 to 18 months before we have a vaccine or herd immunity. And I think to ask patients to pause in their attempts at pregnancy for a month or two is one thing. To ask them to delay pregnancy for 12 to 18 months, I think is unrealistic. And so until we know of clear harm to pregnancy, then I think other than warning patients about what we don't know, trying to study this to get the answers we need, and counseling about the risk of infection and fever is unfortunately the best place where we are, but I don't think we can ask women to wait 12 to 18 months.
Elizabeth, what is your thoughts on that question for the safety of this pregnancy?
Yeah, I've been trying to stay informed, and I've learned a lot being on the task force. And I think really it comes down to staying informed, staying safe, and talking to your family, your partner, about what you feel comfortable with, how long you feel you can delay. It is a little bit unsettling that there's not the data out there to say, oh yeah, you can go get pregnant tomorrow and it's all going to be 100% okay. But for people like me, waiting 18 months really is probably not an option. And so I think it's weighing the data and trying to make really good decisions, having conversations. I know that my husband and I have had conversations with our families about what our expectations are as far as being safe around COVID because of the situation that we're in. And we might have to be a little more careful. We might have to be a little less social and be a little stricter when it comes to the quarantine, because this is really important to us. And if it means that during the cycle that we truly, my husband and I, have to self-quarantine for 14 days and literally not go out of the house, or for a month or 2 months, we're willing to do that. But we would never want to do anything if it came out at some point that it really is harmful in the first trimester. So I think it's staying informed, having conversation, and be willing to make the decisions and sacrifices if needed to stay safe.
And for Elizabeth, there's another question specifically for you, which is a great question. When you go back to treatment, are there things your doctors and their staff should do to help you feel comfortable with new procedures, like masks, for example, that the doctors on the panel are describing?
Yes, I think one thing that I had mentioned on one of our panel calls is I personally just like to be informed, and I like to know what's being done. So one thing that I think as a patient I would like to see is some sort of communication, whether it be verbal or written, just to let me know what the clinic is doing. What are they requiring of patients? What are they requiring of staff? As a patient, I would like to see fewer patients in the waiting room, maybe not have so many patients in for a retrieval on the same day. I'm a big fan of wearing a mask. And hope that I can wear one in the office at all times, just so that, you know, those kind of things make me feel better. So I think the little things, and just knowing that my clinic is taking it seriously, and that as a patient, I want other patients in my clinic to know that, you know, as a patient, I'm taking it seriously. So if I am in the clinic with another patient, I know that my doctor and the other patients are all taking this very seriously and taking the right precautions.
I think that it's also helpful to point out that we now have entered a new phase of telemedicine. And even as we get past the curve, we're still in a COVID-19 era. So I think we need to not push back from the telemedicine opportunities, diminishing the visits that are necessary, and use technology. I mean, people now are able to, you know, let people know when it's their time to come to the office or come up, you know, into the building, wait in the car till, you know, until your time for blood tests are, you know, is present, as opposed to just, you know, the old, where, you know, environment where you had X amount of patients in the waiting area. We now have to be smart using technology and telemedicine to be advocates for safety, and as Elizabeth mentioned, communicate these efforts to give them and our staff the level of comfort that's needed.
That's true. Another question come in about should we be cryopreserving everything for patients who are not urgent for transfer? And the second part of that is there any special precautions that should be taken in the lab to storage tanks until more is known regarding pregnancy? So who feels comfortable addressing that one? That'd be Marcelle, you may be the best one to start with that.
Sure. So for the same reason, I don't think we can ask patients to delay pregnancy for 12 to 18 months. I don't think it's reasonable to have a freeze-all policy and not do transfers. I just think the trajectory of this virus is too low or too long to do that. And part of the goal of the sheltering in place and decreasing interaction and maintaining social distance is to keep that curve flat enough that the individual risk for a patient is low. And so I think that that's why we can't go from strict adherence to shelter in place to throw open the doors and everything goes back to normal. But if we can maintain telehealth, as Dr. Bar-Chama says, and social distancing, both in our clinic, but at the grocery store, everything else we do, and we keep that curve flat, then the individual risk for a patient is low, not zero, but low. And I think that, again, it's a balance of risk versus benefit, and some patients may choose to wait. I suspect most patients will not, given the timeline that we're looking at. In terms of the laboratory, we don't have a lot of information about this. This is not a blood-borne disease the way hepatitis is, the way HIV is. There's been a suggestion that we have separate tanks for patients that are known COVID positive, the way we do for patients who are known positive for hepatitis, for instance. The problem with that is that because we don't have good testing and because there are asymptomatic carriers, it's very difficult to maintain that kind of system. And we really have to sort of say everybody from here forward is presumed potentially positive. And so I think that's one of the factors that SRBT and SART and others are looking into, and there'll be continued guidance in that area. But the lack of good testing, as opposed to being able to accurately diagnose someone's exposure for hepatitis, makes this very difficult to have steadfast plans about the laboratory. So I would look to SRBT and SART to continue to weigh in on that.
Elizabeth, question for you about, if someone proposed, would you be comfortable freezing your embryos and waiting till a later stage to put them back, or what is your thought on that question?
I think it depends on the person and the patient and the situation. I can't say for me for sure. I also, we're looking at also using a third party, and so that sort of would weigh in the decision for me as well. And so I think it really has to be a conversation with your doctor. And it also depends on how long. As Marcelle was saying, I don't know if we're talking 1 or 2 months, or are we talking 18 months, 2 years. So I think that's really a conversation between each patient and doctor, and certain providers may come up with their own recommendations on that particular question.
Question maybe for Natan. Can you address HIPAA or compliance issues with telemedicine?
Look, I think that there is no shortage of webinars or educational material for both patients and physicians describing the environment that we're in with telemedicine. HIPAA is one of the foundations for communication, not just with telemedicine, but in general. We need to be, especially in this field, be extra sensitive and double down on security of this information. So we have to walk into the telemedicine environment with our patients' security and confidentiality as a priority, and accept that some of the platforms that exist may not meet that threshold, while some do. I also just want to reiterate what Marcelle said, which is that we are not, the independent of our surroundings and how this pandemic unfolds. And what we do is also related to what happens at the supermarket, at the barbershops, and the movie theaters, and the prevalence overall. So we have to really be focused and stay on top of the daily changes, and coordinate with all the experts on how to move forward, and not take our eye off the surroundings that we practice in.
Interesting question here is, if a patient is showing symptoms after the IVF stimulation has begun, how do you manage this? Marcelle, you want to take a stab at that one?
Sure. These are all great questions, and we're going to be faced with all of these situations. I think if patients are having symptoms, that those are the kind of patients that probably should be screened, especially if you're considering doing an egg retrieval. But that screening would be nasopharyngeal swabs with PCR. And so they're probably going to need to go to a specific testing center. These are not things that can be self-administered. Most clinics are not going to have someone who's skilled in obtaining those cultures. And just a normal nasal swab is not as accurate as the nasopharyngeal. And so if you have someone who's symptomatic and they're planning an egg retrieval, they should probably be screened with the PCR before you let them into the clinic and let them go through the process.
Another question about testing, and this may be good for Enrique. Is testing, O2 testing with a pulse oximeter an effective screening strategy?
I actually don't know. Maybe Marcelle knows that a little bit better than I
Marcelle
do.
or Natan may know that better. Yeah.
Yeah. So pulse ox or oxygen saturation has been suggested as a way to home monitor people who are known to be infected with the COVID virus or the coronavirus, because patients can seem to be stable and decompensate very quickly, as well as the fact that patients who have coronavirus can have incredibly low oxygen saturation, but still be functioning pretty normally until they get to a level and decompensate. So particularly when hospitals are full, or when you're trying to keep people out of the hospital so that they don't get worse or they don't infect others, then frequently they'll use the pulse ox to measure oxygen saturation at home to look for decompensation. But as a screening tool, it would not be a very good screening tool.
Another question about testing before starting. Someone is asking, is PCR enough plus symptoms, or do you need to have antibody testing or screening prior to starting an IVF cycle?
Enrique, you want to talk about that?
Sure. The antibody testing, we are definitely not there yet. There is a lot of false positives. It's not clear what it means. It's not clear even if it provides immunity at all. So I wouldn't use the antibody testing as a screening tool at all at this point. Maybe next Sunday when we meet again to write the new guidelines, we'll have new data that will change how we feel about this, but that's not. The PCR seems to be not the best test available, but a 70% sensitivity seems to be a reasonable one to start for screening.
Another question here. How do you handle a patient who has COVID, who's tested positive and symptomatic? Would you proceed with an egg retrieval? Marcelle or Natan?
Yeah, so if you're saying the patient is positive with PCR, then I would say no. The potential exception to that, and hopefully because you're trying to be wiser, we're all trying to be wiser about putting people at risk for hyperstimulation and other complications that would take them to a hospital. If you had a patient that you thought was at very high risk for hyperstimulation, even with a Lupron trigger or there's some other reason and they're COVID positive, and again, I would recommend that they be done in a hospital operating room setting with positive pressure, with ability to have anesthesia because they may decompensate. I would not do that in your clinic, and I would probably not do that with the goal of getting eggs to fertilize, but rather just to try to decrease their risk for hyperstimulation. But if someone is known positive, I would not do that retrieval.
Here's a question for Natan. Is COVID present in semen?
So there's a task force put together with the Male Fertility Society of the AUA and ASRM. There was only one publication that has looked at men who are COVID positive and doing PCR on the semen, and it was not detected in the semen. 39 total number of patients were reported in that study. So that's reassuring, but I'm not, and my colleagues are not ready to say that this is the definitive test or study. We have to duplicate that in the United States. One of the things that I think is lacking in that evaluation is associating symptoms versus patients who had been positive, and that's, I think, important in terms of, is there a relationship between viral load and transmission into semen? And I think that we need to look at this more carefully. But the initial data suggests that it is not in the semen.
And one question in general is, how have people coped with the mental health needs of their patients and their staff during this crisis? Have programs increased their counseling health services they provide? And if so, how?
So I know that, sure, I know that our staff has been very active about putting things on our website for patients with resources. We also have been doing telemental health. So in addition to the physicians and the nurses doing telehealth with the patients, our psychologists in our practice are, and they've been very active about being engaged with patients. But we also have put updates from not only the physicians, but from the psychologists in our team on our website. We've utilized ASRM, has resources both for patient mental health, and they've had webinars, and they actually just recently have information about mental health for staff. And so I think ASRM has done a great job about putting things out, and we've utilized those resources from the ASRM as well as having our own psychology staff available to our patients.
Natan, do you have anything to add to that?
No, as Elizabeth mentioned, you know, infertility or fertility treatments are stressful and have a tremendous impact, and the COVID-19 pandemic has just added a real, you know, stressor that is very, you know, I think we're still trying to understand what its impact is, but our priority has been and is to continue with, you know, our psychologists reaching out to patients, being available, hearing from patients, you know, what issues they have, and it was important before COVID, and it's even more important during this time.
Elizabeth, as a patient, yeah, I was going to say, Elizabeth, as a patient, what is your perspective on support for mental health during this time?
Well, I think it's more important than ever, which is why I was, you know, very open in saying that I've had a therapist basically the whole, you know, 4 years I've been doing this. I don't think my husband would mind me saying that he has as well, and we really credit that with, you know, why our marriage is so good after 4 years of this trying journey. And there is a lot of stress right now, you know, around COVID, and it just adds to it. So I think if you can find someone to talk to, I think it makes it better. And I will say too that our therapists are not fertility specialists. They don't specialize in fertility therapy. I think for some people that's probably good to have. For us, we were able to find 2 therapists through a friend of a friend, and that it's been great for us. So I don't think patients should feel like they have to see a certain type of therapist or a certain person. They should feel open to going to whomever they feel comfortable talking to.
And I think the one thing to add is that, and Elizabeth mentioned this before, is information. So I think in terms of patient mental health and stress, the more information you can share with the patient about what's happening in the clinic, what you're doing, how you're going to start back up again, what that's going to look like for them, how soon things will be happening. I think as much as you can keep the patient informed, because it's that lack of information and lack of knowing that I think becomes even more unsettling for patients.
Another question that's come up is how do we handle the asymptomatic carriers or patients, fertility patients who may be asymptomatic carriers, and what is the concern with not detecting that or the impact that may have on risk to others?
Yeah, again, I think
Marcelle, it might be you too.
Yeah, I think the only thing that we can do is to universally take precautions. Masks, social distancing, washing hands, all the time, every day, all patients, and assume that there's risk using those three strategies, although with more physical covering, most healthcare workers have been safe, even with patients with known high viral loads. There's some data, although not great, that patients who are asymptomatic may have less viral shedding. We don't know for sure, but there's some suggestion about that. Maybe we just all hope that that's true. But I think the most important thing is to use these precautions and safety maneuvers across the board, assuming that everybody potentially has risk, and decrease the risk for transmission within your clinic. So cleaning, hand washing, masks, social distancing, all the time.
I think we have one more question here. If you're treating a patient during treatment and you find out they have tested positive for COVID-19, what strategies should you employ from a practice perspective? Do you need to trace all possible contacts, but do you have to test all staff? Do you have to quarantine? Should you close the office? What are measures that should be undertaken?
I'll try to get that, and maybe Enrique can talk about it from an epidemiologic standpoint. So I think from a public health standpoint, you should identify patients or staff and other patients who were within a certain distance of that patient, and at least counsel them, make sure that they're aware. If there's adequate screening, I would go to the health department, or being at the university, I would go to my infectious disease folks and I would say, this is what's happened. Help me figure out what to do in terms of tracing. If you're in a private practice, I think you'd go to the health department and you'd say, what is the capacity for testing and tracing? Because ultimately that's what we need to do as a society. We're not there as a society, but I think you'd have that obligation as a private practice to go to the health department and ask for their assistance in terms of testing and tracing.
Enrique, do you have anything to add to that?
Yeah, so again, we are a huge country, so the situations on each location regarding tracing on what you do is very different by location. So there are different regulations by state of what you should do or who you should contact. Clearly, the health department is a great source to follow. It also will tell you what to do with your staff and how do you treat your staff and what to do with the people in your own clinic who are in contact. So if there are more tests available in the state that you live in, it is possible to test the people who are in your clinic. It is possible maybe to contact the health department. If not, sometimes quarantine for 10 days or 14 days or so on. So it's very dependent on the state, but I completely agree with Dr. Cedars that there is an obligation to communicate with the health authorities to make sure that as a society we reduce this risk for our patients and our staff.
One more question people have about having a patient who may be positive with COVID, low risk of hyperstimulation, but without egg retrieval, maybe at higher risk. Would you proceed with treating? I think that's one of the biggest concerns people have is if someone is positive, what are the concerns about taking someone to the operating room? So low risk of hyperstimulation, would you proceed with that? Marcelle, maybe you can answer that question.
Yeah, I would say no, and it's one of the reasons we've decided, because this is such a expensive process and canceling a patient in the middle of the cycle is so financially, physically, emotionally stressful. We're going to screen before they start the cycle. And somebody asked a question earlier, would you tell them to quarantine for 14 days? And Elizabeth said maybe she would. I mean, we're going to test before. The good thing about testing before is that probably says what you're doing is working, so keep doing it. And then testing again, because that's required by our anesthesia. ahead of time before retrieval. So if we had someone who was negative before retrieval and tested positive, negative before stim and tested positive before retrieval, we would cancel that cycle. And we're counseling patients before they start the cycle that that's a potential risk.
Okay, and the last question we have, and Enrique can probably address this a little bit, is we have a lot of flexibility in our recommendations for treating these patients. And do you run the risk of developing too complex a system, thereby causing more confusion with these recommendations, given the flexibility, than you would if you had stricter guidelines?
Yeah, clearly we run the risk of complications. However, we are a very heterogeneous country. I think we did the best we can with the situation we have. Different locations are facing different situations, different resources, and hopefully, you know, there are new developments that will allow us mass testing and a 5-minute test in everywhere, or a treatment, and this will be an issue of the past. We are, things are changing daily, so I'm hopeful. I'm actually quite hopeful of what that we're going to come out on top of this after we start coming out of our basements. One plug as a scientist, I wanted to
literally,
add that,
I think for you.
one plug as a scientist in the group, I want to add that there are many questions that remain unanswered, and there are many studies that are beginning right now. And I want to encourage all the clinicians out there and all the patients to volunteer for studies, because the questions need to be answered based on data, and your participation is essential to be able to answer all of those questions. So please join the studies, participate, be part of the public health wave.
Well, that was wonderful. Well, I want to thank our panelists, Dr. Bar-Chama, Dr. Cedars, Dr. Schisterman, and Elizabeth Hern, for participating. It was a wonderful exchange and some fabulous questions, and I think we all really appreciated it. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Pfeifer. Thank you to our attendees for joining us. You will receive a survey by email after the session. This session was recorded and will be available on our website in the near future. Please keep an eye out for the registration email for Friday's webinar by the ASRM COVID-19 Task Force, answering patients' questions, followed by Mondays on Mind Body, and Wednesday's webinar focusing on oncofertility during this pandemic. If you have any questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you, everyone.